Welcome to Science Force, where science comes alive.
Hello, everyone, and a very warm welcome to today's Explainer. I'm absolutely thrilled to have you here with us. Today, we're embarking on a truly fascinating journey into a topic that affects millions of people, yet is so rarely understood at a fundamental level. We're decoding urinary tract infections, or UTIs. Whether you're a curious learner just wanting to understand your own body, a life science enthusiast, or perhaps a medical student brushing up on your clinical pathophysiology, well, you're in exactly the right place. We are going to scale right down to the microscopic level and witness the incredible biological warfare happening right inside us. Okay, let's dive straight into this. Here is what we'll be covering today. First, the urinary system basics. Second, the microscopic bacterial invasion. Third, clinical diagnostics and terminology. Fourth, complications and biofilms. And finally, treatments and prevention. Section 1. The urinary system basics. Mapping the sterile plumbing. Let's get into it. Now, to understand an infection, we first need to understand the territory, isn't it? Think of your urinary system as a highly efficient, naturally sterile biological plumbing system. It includes the kidneys, which filter the blood, the ureters that act as transport pipes, the bladder, which is basically your storage tank, and the urethra, the exit tube. Notice how these infections are divided purely by geography. A lower UTI affects the urethra and the bladder. It's deeply uncomfortable, yes, but generally milder. But an upper UTI, that means the bacteria have actually reached the kidneys. This is highly dangerous, bringing on high fever and systemic illness. You see, the physical location of the bacteria completely dictates the severity of the illness. Think of this as an escalation. At the very top, we have urethritis. That's an infection of the urethra alone, characterized by burning, itching, and a mild discharge. Move one step up the plumbing, and we hit cystitis, the infection of the bladder. This is by far the most common type of UTI. It presents with that classic urgent need to go along with cloudy urine and pelvic pain. But right down in the danger zone is pyelonephritis, the kidney infection. If you or perhaps a patient of yours are experiencing high fevers, chills, nausea, and intense back or flank pain, this is an urgent clinical scenario that requires immediate medical attention. Moving on to Section 2, the microscopic bacterial invasion. Meet the invaders. So you might be wondering, who exactly is causing all of this chaos? You might think UTIs are caused by a wide variety of strange external pathogens, but actually a massive 80 to 90% of cases are caused by just one single organism, Escherichia coli, or E. coli. And here's the twist. This E. coli is normally a completely harmless, helpful resident of our own intestinal tract. It is, quite literally, an inside job. The remaining 15% are caused by other bacteria, like Klebsiella or Proteus, and very rarely fungi like Candida, usually in immunocompromised individuals. So how on earth does intestinal E. coli breach our sterile urinary tract? Well, we trace what is known as the ascending infection route. Step 1, the bacteria originate from the anal region. Step 2, they transit over to the urethra. Step 3, they multiply and move upward into the bladder. And step 4, if left completely unchecked, they ascend to the kidneys. Now, we absolutely must note an important anatomical reality here. Women are significantly prone to UTIs simply because the female urethra is much shorter and its opening is physically closer to the source of the bacteria. The path for these invaders is simply much quicker. Now, for the life science students tuning in, let's actually look at the cellular mechanics here, the pathophysiology. How do these bacteria hold on against the strong flush of urine? Well, they possess these incredible microscopic grappling hooks called pili or fimbriae. They use these virulence factors to physically bind and latch tightly onto the urinary tract lining. The very moment they attach and start multiplying, your body's immune system detects the breach. It immediately sends a swarm of white blood cells, neutrophils, and cytokines to the area. And this intense inflammatory immune response is actually what causes the painful symptoms you feel. That burning, it isn't just the bacteria, it's the fierce battlefield of your own immune system fighting back. Section 3. Diagnosis and medical terminology. Speaking the clinical language. Right, for the medical students and clinical professionals joining us, let's speak the clinical language for a moment. First term up is pyuria. This is the clinical presence of pus cells, which are essentially white blood cells in the urine. Remember that intense inflammatory immune response we literally just discussed? Pyuria is the direct microscopic evidence of that battle. Your body is shedding the soldiers that fought the infection right out into the urine. Next, we have bacteriuria. Quite simply, this is the presence of bacteria in the urine. Interestingly enough, a patient can have bacteriuria and show absolutely no symptoms whatsoever. We call this asymptomatic bacteriuria. Clinically, we generally don't treat this unless the patient falls into a special category, like a pregnant woman or a patient preparing for urologic surgery, where the risks of ignoring it are simply too high. Then there's dysuria, and if you've ever had a UTI, I am sure you know this symptom all too well. Dysuria is the medical term for that painful, irritating, or burning sensation experienced during urination. It's essentially the most universally recognized layman symptom, just translated into clinical terminology. Moving on to hematuria. This is the presence of red blood cells, or blood, in the urine. Now, to a patient, seeing a pink or red tinge in the toilet bowl can be incredibly frightening, but clinically, we know this is actually a very common feature that stems from the severe inflammation and irritation of the bladder lining. And finally, nocturia. This is that frequent, urgent need to wake up multiple times during the night to urinate. The inflamed bladder is highly irritable, you see, and it sends constant false signals to the brain that it needs to be emptied, which disrupts the patient's rest entirely. So the big question, how do doctors actually test for all of these urias? Well, the diagnostic process heavily relies on the urinalysis and the urine culture. A rapid urinalysis dipstick checks for leukocyte esterase, which is an enzyme from those white blood cells, and nitrites, which many bacteria produce. But the absolute gold standard is the urine culture. We take the urine, we grow the bacteria in the lab to see exactly which organism is causing the trouble, and, most importantly, we test it against various medicines to determine antibiotic sensitivity. We absolutely have to know which specific weapon will neutralize this specific invader. All right, Section 4, Complications and Biofilms, when the infection fights back. Here is an absolutely crucial point to consider. Why is it that some UTIs resolve so quickly with a simple course of medicine, while others just keep coming back over and over again, stubbornly resisting our very best antibiotics? The answer actually lies in a fascinating, though admittedly troublesome, microscopic defense mechanism known as the biofilm. Bacteria are incredibly smart. Sometimes, especially when a foreign object, like a urinary catheter, is present in a hospitalized patient, the bacteria group together and secrete this thick, slimy protective shield all over themselves. This shield is the biofilm. Our antibiotics have a tremendously difficult time penetrating this barrier, and this leads to chronic, stubborn, resistant infections, frequently termed catheter-associated UTIs, or CAUTIs. It makes medical treatment incredibly complex. And finally, Section 5, Treatments and Prevention, Evicting the Invaders. The good news is we are certainly not defenseless here. When an infection takes hold, our mainstay weapon is targeted antibiotics, drugs like nitrofurantoin or ciprofloxacin, chosen specifically based on that urine culture we discussed earlier. Supportive care is also vital. Aggressive hydration physically flushes the bacteria right out of the plumbing. But I have to sternly warn you about the risks of leaving a UTI untreated. The bacteria can ascend, causing permanent kidney damage. Even worse, if they cross over into the bloodstream, it triggers sepsis, which is a life-threatening systemic crisis. And in pregnant women, untreated UTIs carry severe risks of premature birth and low birth weight. It's definitely not something to be ignored. Thankfully, preventing all of this is highly actionable. Here are some incredibly practical everyday tools you need to keep your sterile plumbing safe. First, drink plenty of water daily to maintain a strong flushing flow. Fourth, please don't hold your urine for long periods. Stagnant urine is basically a breeding ground for bacteria. And lastly, skip the excessive use of harsh soaps, which can really disrupt the natural protective flora of the body. Wow, we have covered some immense ground today, haven't we? From basic anatomy to the molecular grappling hooks of E. coli, right through to clinical diagnostics. So I want to leave you with this final thought. The next time you or a patient feel that urgent burning sensation, will you now recognize the fierce microscopic battle happening right inside that sterile plumbing? Thank you so much for joining me on this explainer. Keep learning, stay curious, and I look forward to decoding another fascinating topic with you.
Thank you for watching Science Force.